You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 20th, 2023. This week, listener feedback, oral anticoagulation in patients with intracranial hemorrhage, a great example of statistical significance but not clinical significance, and the issue of statins and diabetes. First up, I want to thank everybody for the ratings and reviews. We're up to 699 ratings on Apple Podcasts, so please go ahead and rate and review this podcast. It helps others find us. First is listener feedback. I received 2 detailed pieces of feedback this week, one on the matter of imaging during PCI and one on my criticism of the STEP-HFpEF trial. These were both super good comments, and I will spend some time on them because there's education to be had. First, the matter of imaging during PCI. I covered a paper in the European Heart Journal that had documented extremely low use of intravascular imaging for PCI, which I found weird because I also found multiple clinical trials and meta-analysis showing that intravascular imaging reduces MACE outcomes. Now, that's interesting because unlike my field of AF ablation, interventional cardiology actually had submitted imaging to RCTs and found it to be beneficial. We do imaging in AFib ablation, but there's no RCTs. Well, I actually found a meta-analysis of only RCTs, first author Islam El-Gendi, and this was in Circulation CV Interventions, and it found a substantial benefit. I'll link to that paper. And then, of course, the ultimate trial of IVUS versus angiography in 1,500 patients who had a drug-eluting stent found that imaging reduced the primary endpoint of target vessel failure by 47%. 3-year follow-up of that trial has upheld that lower rate of target vessel failure. But of course, intravascular imaging adds cost and time to the procedure. A very senior professor of cardiology sent me a nice email offering explanations for low use of intravascular imaging in the US. He wrote that, quote, most of the studies supporting IV imaging, intravascular imaging, are poorly designed observational studies. The randomized clinical trials evaluating intravascular imaging have primarily been performed in select, high-risk populations and primarily outside of the U.S. He went on to say the differences detected in these studies have been small, and although statistically significant in some cases, the clinical relevance is less clear. He then noted the most recent, largest, and only RCT in the U.S. that evaluated intravascular imaging-guided PCI versus angiographically guided PCI is the Illumin-4 trial. This was a select group of high-risk PCI patients that had, long lesions, bifurcation lesions, CTOs, etc. And despite this, it was a negative trial. He noted that I actually covered the trial in September, and I actually did. My commenter went on to explain this is why he thinks imaging is not currently recommended for routine use in PCI. And he said, or wrote, I think many of us in the interventional cardiology community appreciate the benefits of imaging and use it in higher risk cases such as the left main, but whether or not it should be used routinely in all cases still requires more data. And my comments to these comments are that, yes, he's correct about the Illumin-4 trial, but I would also note that in the Illumin-4, there was a 10% reduction in target vessel failure, but it did not reach statistical significance. And perhaps more important, the incidence of definite or probable stent thrombosis occurred in 0.5 versus 1.4 in the vascular and angiography group, respectively. That's a 64% reduction in stent thrombosis. These are low numbers, yes, but that p-value was actually 0.02. I would also point out that when Illumin 4 was presented and published, there was also another RCT, one with perhaps a little less vigorous methodology called October, and it found a statistically significant 30% reduction in a MACE endpoint with imaging. So I guess I agree that more data is needed. There are 2 more trials on imaging that are recruiting and yet to report. This is the IVIS-CHIP and IMPROVE studies. But to the outside observer, me, looking at only the data, the preponderance of the evidence seems in favor of using imaging. I guess if I were to have a PCI, I'd hope that it was associated with a high degree of symptoms or associated with an acute syndrome, and that the operator used imaging. Now, my commenter also pushed back against my negative opinions of FFR, but I will table that discussion for another day. It was actually quite a strong rebuttal. The second bit of listener feedback I received was strong pushback against my criticism of the STEP-HFpEF trial. Recall that STEP-HFpEF led the ESC hotlines recently and was published in New England Journal of Medicine on September 21st of this year. STEP-HFpEF randomized about 500 or so patients with HFpEF and obesity to semaglutide versus placebo. They measured 2 primary endpoints, weight loss and results of a quality of life questionnaire. Of course, this trial was positive. Patients lost weight. We know that semaglutide does that. So positive endpoint number 1. And patients felt better, so positive endpoint number 2. Then last week, the authors published a sub-study looking at these results based on ejection fraction. They subdivided a normal ejection fraction, preserved ejection fraction, into just barely normal, really normal, and supernormal. Now, as an Indiana University Feigenbaum trainee, this is antithetical to my understanding of echocardiography, so I was critical of the sub-analysis. I called STEP-HFpEF a marketing study, which, given the multitude of positive findings in GLP-1 agonists, hardly seemed like a necessary thing. I mean, we already have great data with these drugs, and we're going to get more. Well, a person with deeper knowledge of the trial sent me a very cordial explanatory email. It's educational, so I will discuss it. My commenter wrote that the idea for STEP-HFpEF came about because of a fierce, quote-unquote, fierce belief amongst heart failure experts that GLP-1 agonists were bad in heart failure. The reasons why they were bad? Well, the heart failure community believed that people who were heavier with heart failure had better outcomes and that weight loss was bad if you had heart failure. They also believed that GLP-1's increased heart rate and a higher heart rate in heart failure is bad, so that would cause trouble. And finally, that the FIGHT and LIVE trials in HFrEF showed that the outcomes were worse with GLP-1 agonists than placebo. But I would note that these were liraglutide trials in HFrEF, so a little bit different, and they were non-significant. So my commenter tells me there was a push to do a large outcomes trial with semaglutide and HFpEF, but that did not work out. There came to be a compromise wherein STEP-HFpEF happened. My commenter also reminded me that STEP-HFpEF measured NT-proBNP and CRP and heart failure hospitalizations, and that this commenter was encouraged by the reduction in these biomarkers, and a very small number of heart failure hospitalizations did favor semaglutide versus placebo. My commenter's take-home was that STEP-HFpEF is a beginning. It gave the heart failure community reassurance that GLP-1 agonists should be studied in HFpEF and that these trials actually will be done. Now, let me just make some comments about these comments. First, I am thankful to receive such pushback. I learn a lot from it, then I try and pass this knowledge on. Second, we need to address this ridiculous notion that our writer spoke of regarding the idea amongst anybody, especially heart failure people, that weight loss is bad because of the quote-unquote obesity paradox studies. If you remember one thing from this week, remember that there is no obesity paradox. There's no obesity paradox in heart failure, in AFib, in coronary disease. all of these studies that purport to show that thinner patients with heart failure do better or that obesity is protective are totally and utterly marred by collider bias. Go look at these studies if you don't believe me. They all restrict enrollment of patients. They all have a collider. I will link in the transcript to a letter that I co-wrote with Dr. Steven Stovitz regarding the lack of obesity paradox. Now, my second response to these comments regards the tension of imperfect trials. I know that no trials are perfect. Big outcome trials are best. The writer made me think that there are probably steps on the way to these bigger trials. And STEP-HFpEF may be one of these steps. Okay, I get that. I see that. But still, I don't see the need for sub-studies of foundational trials that are flawed. And when a trial like STEP-HF are published, it's the job of the authors and us consumers of evidence to appraise them with severe caution. And I guess that is the role of this podcast. Okay, the second topic is interesting, the role of anticoagulation in patients with intracranial hemorrhage. Even that title might give you anxiety, right? Oral anticoagulation and intracranial hemorrhage, that sounds crazy. But actually, no, it isn't crazy. This is one of those knee-jerk ideas in medicine that needs to be shuttered. Now, let me try first with the story and then with data. First, a story of a patient that I see every year. We initially saw each other when he had atrial fibrillation and an intracranial hemorrhage and for consideration of left atrial appendage occlusion. Now, as I do with all patients who have stroke and AFib, is I visit our neuroradiologist to review the MRI. It turned out that this person's ICH was a clear hemorrhagic transformation of an ischemic stroke. So in consultation with neurology, we waited a little bit and then we started a DOAC. This person has done fine. The MRI image is burned into my brain because if you were solely to go by dogma and knee-jerk and words in the chart, he might have received suboptimal care such as no anticoagulation or perhaps even worse, an appendage occlusion device. Now, I know this is just a story. Now let me show you some data. The journal Lancet Neurology has recently published a meta-analysis of 4 RCTs that studied the use of anticoagulation, almost all of them DOACs, versus no anticoagulation or aspirin in patients who had, wait for it, an intracranial hemorrhage. Now, this was a particularly strong meta-analysis because they had individual patient-level data. It was about 400 patients, older patients, CHA2DS2-VASc around 4. About a third of these patients had a lobar intracranial hemorrhage. Now, you'll be able to remember this study because its abbreviation is the Collaboration of Controlled Randomized Trials of Long-Term Oral Antithrombotic Agents After Spontaneous Intracranial Hemorrhage, or the acronym COCKROACH. The primary outcome was stroke or CV death. The hazard ratio, get this, 0.68, confidence interval 0.42 to 1.10, so we should translate. Patients who were randomized to a DOAC had a 32% reduction in stroke or CV death. But of course, the confidence intervals are wide, and the upper bound is 1.1, so it's greater than 1, and this is considered not statistically significant. But let's look at some of the secondary outcomes, like major ischemic cardiovascular events. Now, it was 4% versus 19%. That's a huge 73% reduction with oral anticoagulation. Now, this endpoint was primarily driven by a reduction in stroke. Now, I know your next question is, what about bleeding? In the category major hemorrhagic event, it was 7% versus 5%. Translation, no different. For intracranial hemorrhage, it was 6% versus 3%. Higher for oral anticoagulation, yes, but small numbers, and not enough to affect the primary endpoint. And then one of the interesting endpoints in neurology is death or dependence. Dependence described by a modified Rankin score greater than 3. This was also no difference at all. Now, other notes from the authors. First author, by the way, is Rustam Al-Shali Salman at the University of Edinburgh. They noted that there are 5 ongoing RCTs randomizing patients with intracranial hemorrhage to oral anticoagulation or not, and these are due to report in the coming years. Now, let me first point out the weaknesses of this data and the uncertainties. Then I'll do the strengths. First is that there are small numbers. Whenever a primary endpoint, here stroke or CV death, is reduced by 32%, yet is not statistically significant, because the lower bound is a 60% reduction and the upper bound is a 10% increase. That tells you have insufficient number of events and there's a risk of noise rather than signal. The second issue I think here is the variability of patients. Intracranial hemorrhage is a broad category, and you can be sure that patients enrolled in these trials were scrutinized closely. I think it would be very wrong to translate this data to all patients with intracranial hemorrhage. In fact, for instance, there is also in the Lancet a rapid correspondence regarding early termination of a trial called ENRICH-AF. This is a study of edoxaban versus no edoxaban in patients with lobar intracranial hemorrhage and patients who had cerebral amyloid angiopathy-related bleeding, and this was reviewed by a DSMB and stopped because of an increased risk of bleeding in the edoxaban arm. The third issue that's not answered here is the timing of oral anticoagulation initiation. This too is a nuanced thing that's going to require a lot of consultation with neurology and hard thinking. But this signal from this meta-analysis, albeit limited, argues strongly for dispensing the idea that intracranial hemorrhage equates to no anticoagulation and or doing appendage closure. It also argues for getting more data, and there will be 5 more trials. Stroke, I remind everybody, is a systemic disease. Oral anticoagulation is a systemic treatment. Appendage closure is a focal treatment, one that has procedural complications and often comes with the need for antithrombotic treatment. Intracranial hemorrhage requires us to stop and think, phone a friend, look at scans. Also keep in mind that we are now studying factor 11 inhibitors, right? This is oral anticoagulation that may prove equally effective in thrombosis and better for bleeding. Again, it remains to be seen. Next topic, JAMA has published a great teaching case for critical appraisal people. Specifically, this is a case wherein a result is statistically significant but not clinically significant. This is fun. Get this. There is a program called A Million Hearts Model. The idea is good, is to pay healthcare organizations to assess and reduce cardiovascular risk. Note first that they are not paying for achieving anything, just to measure risk and try to reduce risk in the highest people. That's good, right? Because paying for achieving something like the number of mammograms you get your patients to have is bad, ridiculous in fact. Now, the other thing is that this massive incentive program wasn't just hoisted upon people. It was studied in RCT form, and that too is good. The gist of this is that CMS paid healthcare organizations $10 for every patient who then had a submitted 10-year risk score. Now, you know, that one that so few people get before a statin treatment. I like the pooled cohort equation that kicks out a 10-year risk because it is easy and it quantifies a risk. Then you can talk to patients about how much or how little statins reduce the absolute risk, and people feel differently about these numbers. Randomization of this study was at the organizational level. If an organization agreed to be randomized, they were either put into the intervention group or standard care group. It was offered to 516 healthcare organizations, but only 342 entered the program. The study population were older adults without a previous MI or stroke, and they had moderate or high cardiovascular risk. The primary outcome was first-time cardiovascular events, MACE, MI, stroke, TIA, and they identified this in Medicare claims. There were 3 big results. Over median follow-up of 4 years, the intervention group, that is the healthcare organizations that had incentives to measure 10-year risk, had a relative 3.3% lower rate of cardiovascular events than the control group. The adjusted hazard ratio, get this, 0.97. P-value, 0.09. I'll get back to that. Now, these relative effects represent a tiny absolute risk reduction of only 0.3 percentage points in the probability of a CVD event over 5 years. It was 7.8% versus 8.1%. There were no significant between-group differences in Medicare spending on CVD events or in overall Medicare Parts A and B spending. So the authors concluded that this is great. Results support guidelines to use risk scores for CVD prevention. So my comments. I do love the PCE pull cord equation. Whenever patients or friends ask me whether they should take statins for their cholesterol, I say, forget about cholesterol and let's talk 10-year risk. In fact, I think statins should be over the counter. Put a risk calculator in their aisle and let patients decide. Statins have to be safer than NSAIDs, for instance. But this particular study has issues. The primary endpoint was reduced by 0.3 percentage points. That is an NNT of more than 300 for a non-fatal event over 5 years. Calculate that per year. In other words, though the authors claim significance, it's hardly a win for patients. And that's not hard to understand, is it? I mean, how much would you expect the measurement of a 10-year risk to incrementally improve CVD health relative to everything else? I mean, standard care is pretty good, but there are also many factors on the causal pathway to having a cardiac event, like your neighborhood, air pollution, diet, smoking, and how about just luck? To me, a better measure in this study would have been to assess patients' understanding of risk. Do patients who get their 10-year risk score told to them better understand things? I think it's yes, but that's an empirical question. Now, the other thing about this study is its lesson in statistics. Literally 99% of studies that I've covered and read in the last 10 years use a p-value threshold for significance of 0.05. Some statistic experts have even recommended using stricter measures such as 0.005. This study uses a p-value of 0.10, and the p-value of the primary endpoint was 0.09. I'm wondering about this, so I searched the manuscript for justification, and here is what I found. Quote, as with other CMS tests, we pre-specified a p-value threshold of 0.10 to, quote, balance the risk of type 1 and type 2 errors. That's funny, isn't it? To balance the risk of false positives and false negative results, as if going against the grain of accepted medical evidence provides the answer to one of epistemology's greatest challenges, and that is sorting out signal from noise from these studies. A final topic, and it's a short one, statin choices. The BMJ has published a substudy of a trial called LODESTAR, which I covered back in April 7th edition. The main LODESTAR trial came out at ACC, and JAMA published a study about 4,000 patients with coronary disease. Treatment A was a treat-to-target LDL strategy. Treatment B was just use a high-intensity statin, either rosuvastatin 20 or atorvastatin 40. The primary efficacy endpoint was MACE, that is death, MI, stroke, or revascularization. The treat-to-target strategy was found to be non-inferior to the high-intensity statin arm. It was 8.1 versus 8.7%, and this easily met non-inferiority. In fact, it was less. Okay, so LODESTAR was a 2x2 factorial randomization study wherein the other two strategies were randomized the type of high-intensity statin, rosuvastatin versus atorvastatin. Here's the quote from the paper, quote, each group of patients was secondarily randomized 1-to-1 manner to receive one of two statins, rosuvastatin or atorvastatin. Now, that's the topic of the BMJ study published this week. And there was absolutely no difference in MACE between the two statins. The curves were nearly superimposable. The most interesting finding, though, was a secondary endpoint. The rosuvastatin group had a higher incidence of new-onset diabetes requiring initiation of anti-diabetic medication. This was 7.2 versus 5.3%, a hazard ratio of 1.39, so a 39% increase. And there was also an increased risk of cataract surgery in the rosuvastatin group. So my comments, I tweeted about this and learned quite a bit from the responses. The first thing to say is that it sounds bad that one group had more diabetes. We've also heard that from statins in general. We know this is bad because diabetes is bad, so you don't want it. Plus, if it causes more diabetes diagnosis, that means an extra medication. But the issue here, I think, is a lot less than what it sounds like. First, let me talk about the issue of statin-induced diabetes. I think this means that more patients reach a hemoglobin A1C threshold. That is not the same as developing complications from diabetes, such as heart disease events. For instance, it's actually the opposite with statins, right? Statins substantially reduce cardiovascular events. The second issue with extra medications because of increased diabetes diagnosis, yes, that may be true, but A, there was a statistically significant greater use of ezetimibe in the atorvastatin group, so it may end up being a wash. And B, these additional new medications for diabetes could include an SGLT2 inhibitor or GLP-1 agonist, both of which confer cardiovascular benefits. So my takeaway is that it is good to have comparative research within drug classes. I'd love to have, for instance, an apixaban versus rivaroxaban study. Secondly, I wouldn't get out of sorts about the diabetes signal with statins, and I think either rosuvastatin or atorvastatin are equally okay to use for cardiovascular risk reduction. So that's it for this week in cardiology. As always, I am grateful that you listen. Thank you. Thank you for the feedback. And remember, if you like this podcast, please give us a rating, write us a review. Even those 1 or 2 sentence reviews go a long way to help others finding us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.